Hello, everyone, and welcome to today's webinar, Choosing Wisely Success Stories, Learn How to Lead the Way in Providing the Highest Quality Care. My name is Amanda, and I'm the Marketing Manager here at AOTA, and I'm going to point out a few things about today's presentation. First, CE. You can earn one CE contact hour for each webinar attended during Member Appreciation Week. At the conclusion of the webinar, you will receive an email from AOTA Webcast containing a link to your CE certificate. However, you must stay on for the entire webinar until you view the pop-up screen that says the webinar is now over in order to receive your CE certificate email. You will have through December 31st to obtain your CE certificate. Next, questions. On the left side of your screen, you'll see an Ask a Question box. This is for you to type in questions you may have for our presenters throughout the webinar. Questions will be answered towards the end of the webinar, and the presenters will do their best to answer as many questions as time allows. And last, resources. The PowerPoint presentation for this webinar is available for download and can be found in the Event Resources box located just below the Ask a Question box. Simply click on the pull-down arrow to view the document and download. And with all of that helpful information, let me introduce today's presenters, Phyllis Simon, Dawn Nilsen, and Renee Watling.
Welcome. My name is Dawn Nilsen, and we're very happy to be here with you to talk about AOTA Choosing Wisely. So our learning objectives, we're hoping that during this webinar you'll learn about AOTA's 5 recommendations, why those recommendations are important to integrate into clinical practice, and then we hope to provide you with some practical suggestions on how to actually integrate these recommendations into clinical practice with a specific focus on several of the recommendations. So first, what is Choosing Wisely and why is AOTA participating in it? Well, Choosing Wisely is an initiative of the American Board of Internal Medicine, and the primary aims of this initiative are to promote meaningful conversations between practitioners and clients to ensure that appropriate and quality care is being provided. So specifically that interventions and assessments are supported by evidence, that they're not duplicative of other tests or procedures already received, and that free from harm, and that they're truly necessary. So the American Occupational Therapy Association made a commitment to join Choosing Wisely in 2016, and with support and input from AOTA members, the board of directors, and staff, they implemented a 3-phase process to develop and publish the list of the 5 things that patients and providers should question. And so here are AOTA's 5 things. Our 5 recommendations are: number 1, don't provide intervention activities that are non-purposeful. 2, don't provide sensory-based interventions to individual children or youth without documented assessment results of difficulties processing or integrating sensory information. Recommendation number 3, don't use physical agent modalities without providing purposeful and occupation-based intervention activities. 4, don't use pulleys for individuals with a hemiparetic shoulder. And 5, don't provide cognitive-based interventions without direct application to occupational performance. And so today we're going to be highlighting 3 of these recommendations, recommendation number 1, 2, and 4. But you can find information about all of these recommendations and ways to integrate these into clinical practice at the website that you see on the slide here. So I'm going to turn this now over to Phyllis Simon, who's going to be covering recommendation number 1.
Hi, everybody, and thank you for joining us today for the topic. So the recommendation I'm covering today is don't provide intervention activities that are non-purposeful. And when we look at the pictures that are listed there, or when we think about what purposeful activities are, we want to think about things that are tasks that are part of our daily routines, hold meaning, are relevant to our clients, and have perceived utility in the performance in the activities that our clients perform every day. So what we want to really do is focus on what are the things that we can use to replace an adjunct and take the place of these activities. Part of the barriers I think sometimes that clinicians face are some of the things that are listed here, but probably I foresee some of the biggest ones are habits and routines of clinicians. You know, it's what clinicians are used to performing, what they see in the clinic, what's available, the limited supplies and equipment that some facilities have and departments have. And very often we go to what's convenient, what we're used to, what we've used in the past, perhaps what patients do, but we have to think about the perception also about what these tasks and activities mean to our patients. When we look at what's valued, you really question, does the patient value putting pegs into a pegboard or using cones or even the ARC? Is that the value? Are those things that are meaningful to the patient? You know, it's very easy to sort of create activities and we can all modify how they're being utilized, but you know, do they stimulate the patient, or is it of interest or motivation? And in the end, what it really comes down to are showing outcomes, and we have to connect with what the outcomes represent. Productivity standards, system and reimbursement mandates definitely are playing a big role, particularly now with changes that have come about, particularly in the last month. And this is a big challenge. We know the use of, it makes it difficult when we have these external forces to provide services that are occupation-based. It definitely takes considerable more time for clinicians to implement occupation-based activities. So what hopefully will come out of this discussion are ways that we can overcome these types of barriers. As I alluded to before, we know many of you may be undergoing this yourself and feeling it, but the influence and the impact of our new reimbursement model really sort of strikes back and makes you think about how do we really emphasize the value of OT services. Value-based care really reinforces the need that we need to look at patient-centered care and justify the outcomes that we're doing. And when you use non-purposeful activities, you have to think about how is that impacting the value of OT services. Is that what we want our patients to connect with? Is that what's going to be achieving our client-centered goals? So the emphasis now really should be on the provision of evidence-based OT for the improved outcomes. And we know that research has shown, and our profession has already shown, that the use of occupation and meaningful activities has been connected to better outcomes for our patients. So that's a little bit more about where we want to be able to utilize these types of interventions. You also want to make sure within this new system and this new model that we're really looking at the full scope of practice for OT. It's looking at functional cognition. It's looking at all the occupation-based activities that our clients need to perform across the lifespan. And there are many ways that these activities can be implemented into our clinical practice. The other big impact of this is the change in the models to group and concurrent models of treatment, which is being utilized, I'd say, probably more so now than in the past because of the changes. And, this actually, instead of thinking about it as a barrier, we might want to embrace this and think about the opportunity of using these models as a nice entree into incorporating occupation-based and more meaningful and purposeful activities. So here are some of the recommendations that we might have. The first part is, how do we get ourselves to serve as agents of change? It's hard to sort of change our ways. Everybody understands the demands that we're up against in the clinic, but sometimes we sort of say it takes a village. So sometimes one person has to take the bull by the horn and sort of promote this change, and there are lots of different ways that can be done. And I've been looking online and getting some really creative ideas that people have come up with, and people have have even some of the resources that AOTA has put together is people have, I remember I worked in a clinic where the equipment closet door was locked and everything was put away, and we only were able to use and generate ideas. We're a bunch of creative clinicians, and I think putting our minds together to create and generate this list may make it easier for all of us. So definitely think about creating that bank of occupation-based activities, and there could be lots of ways that therapists and clinicians can do this. Creating boxes or kits of activities is really helpful for different kinds of tasks and activities that people might engage in, different types of work tasks. Use the people that are in your facilities and around in your program, whether it's the kitchen staff or the maintenance people, or it's the person answering the phones and letting the people in the doorway. Creating environments and the context of the clinic. Think about what's around. Are there simple ways that you can modify the environment and the context of the clinic? Can you hang up a coat rack? Can you use a dresser drawer instead of or another type of cabinet door that sort of simulates and creates a home environment? Can you create a workstation that's available within the clinic? These types of things will all promote the use of occupation and more purposeful activities. The use of groups, as I started alluding to, people have been saying that they've been doing, of course, cooking groups, but also different types of book clubs and different types of activities that people have worked on perhaps in their former lives and looking at what's meaningful and relevant to them. So these were just some of the recommendations. Again, we're backed up. We need to take out and remove the cones and the pegs and the arcs from our clinics. We need to become friends and make frequent stops at the dollar stores, promote like different types of drives where perhaps people can come in and donate activities that would be used and represent more meaningful and purposeful activities for all of our clients. So I'm going to pass this on now for recommendation number 2.
All right, thank you. This is Renee Watling, and I am going to be addressing recommendation number 2, which states, don't provide sensory-based interventions to individual children or youth without documented assessment results of difficulties processing or integrating sensory information. And I want to just begin by recognizing that at the core, this recommendation is really about implementing best practices for the children and youth that we work with. It's not a new idea. It's very grounded in the OT practice framework and in the processes that we have used since the beginning of our profession. But it is very relevant today in the current climate of increased recognition of this need to be addressing the sensory needs that are being recognized in this population. So the focus of this recommendation is really to link our treatment decisions to the evaluation results that we have. And we've seen in recent years this increased recognition that sensory challenges are actually a real phenomenon. When that idea was first presented, there was a lot of skepticism and a lot of pushback. Excuse me. But in the last, I would say, decade to 2 decades, there's been an increased rate of acceptance and, again, recognition of these needs as being very valid. And with that, there's been an increased demand to be addressing sensory needs through interventions, and oftentimes people expecting or demanding those interventions to be delivered relatively immediately. And so the idea here with this recommendation is really to be able to step back and rely on our professional documents and our processes to guide practice and to give practitioners in the field a place to support them in implementing practices in accordance with our framework and our code of ethics. So some of the barriers to implementing this, I think, can be summed up in these 4 points. And first of all, requests that come from other people, particularly other professionals. So oftentimes we may have physicians that are referring children to outpatient services, specifically requesting sensory treatment or sensory interventions. And that can put the practitioner in a difficult spot as they need to first, do a full evaluation and really assess the needs of the client and collect that data that determines where the deficit areas lie before a decision is made around intervention methodologies. We also see increased requests for sensory interventions happening frequently in school-based settings. And this often comes up where teachers are encountering a child in their classroom who maybe is demonstrating some behaviors that could, in fact, be sensory-based, and the teacher's looking for a quick fix. They've maybe have had experience with other students who've responded well to sensory interventions, or they've heard stories about the effectiveness of sensory interventions, and they just want to have tools brought on board very quickly to address the need of a new student being identified. And again, this can really put the practitioner, the OT practitioner, in a compromising position as they want to try to address the teacher concerns, but really need to first back up and implement this best practice approach of completing that assessment in advance of intervention recommendations. A second barrier to implementation is lack of access to appropriate measurement tools. And I think we can see this playing out in a couple of different ways. First of all, could be the possibility of not having appropriate measurement tools available in a particular facility. So maybe there are a few tools available, but they're not really appropriate for the particular clientele that's walking through the door. Another scenario is that as we have had increased development of sensory-based measurement tools, most of them currently are caregiver report tools, and very few are performance-based measures. And we know that that then is only giving us one perspective around the sensory needs that might be present for an individual child. And so we can have lack of access either in terms of the real access in a facility, or even just lack of access across the profession in terms of the tools that have been developed and made available. So that can be another barrier to implementing this recommendation. A third potential barrier is limited time to conduct evaluations. And, we all are feeling that, the pressure and feeling the squeeze to get interventions implemented quickly. And that does then reduce the time that we have available for evaluations. It's been many years now, but when I started as a practitioner, I was allowed 4 visits to conduct a full assessment of my clients. And those days are long gone, and we're not going to be getting those back. But what has happened then is that we need to focus our evaluations really directly to align them with the referring recommendations of the clients that we're seeing. And if those referring recommendations don't have anything to do with sensory challenges, then it's very likely that we're not going to be including those types of tools into the evaluation process. So it may be that it's a few visits down the road as we get to know the child better that we're starting to see red flags, and we may need to be circling back and re-implementing some evaluation methods even after we've started intervention stages of treatment. The fourth barrier to implementation has to do with lack of training in how to best interpret the results of the assessments that we have conducted. And I think that this is a very real situation that many practitioners find themselves in. And again, as we've had this increased recognition of the need to address sensory issues, and we've had this increased demand for our services, we have practitioners who are not well prepared, that are trying to implement the sensory-based evaluations and then trying to interpret them and make treatment recommendations based off of the findings. And if that particular practitioner does not have solid understanding of the theory underlying sensory integration and sensory processing needs, or perhaps is not well skilled at thinking beyond just what does a standardized score mean, but how to really think about the underlying function that score is representing, that can really present challenges in terms of linking the decisions around interventions back to those assessment results. So that's a place where practitioners may be feeling some pressure or feeling the gap. So when we look kind of overall at this particular recommendation, there are 3 key points that I really want people to walk away with today. And first is that our best practice standards require that assessment be completed prior to making intervention decisions and delivering services. And that really needs to be held on to regardless of the referral request for a specific treatment methodology. And I want to encourage people that regardless of who is putting that pressure on you, whether it's a physician referring for sensory treatment, whether it's a teacher asking for it, or even perhaps a parent who's asking to have their child receive services through a sensory perspective, really standing firm in that process of conducting a solid assessment before making those intervention decisions. The second key point is obtaining that specialized knowledge of sensory integration theory prior to evaluating sensory needs and implementing sensory interventions. And this is something that then becomes the personal responsibility of each individual practitioner. We don't have educational standards that prescribe the type of education that entry-level practitioners should have related to sensory integration, but we frequently self-identify our profession as having expert knowledge in this area. So it really then becomes, again, the individual practitioner's responsibility to make sure that they do have a solid knowledge of the theory base and are well-skilled at evaluating sensory issues, interpreting the sensory assessment data, and then figuring out what to do regarding intervention. The third key point is the need to be familiar with the emerging research surrounding sensory-based interventions and being able to use that evidence to provide a rationale for your treatment decisions. This, again, is just, it's best practice. If you are familiar with some of the research in this area, you know that there has been a lot of controversy around the findings, and that is well-founded controversy because there are some problems with the historical evidence. However, we also have a lot of current researchers doing work in this area, and there is new evidence being made available present day. So I think that it's very, very important that practitioners find ways to stay abreast of the literature and really learn how to use it well to support your treatment decisions. So I encourage people in that. To wrap up this recommendation, I just want to make a few specific points about how you can go about implementing this recommendation. So first, revisiting this idea about obtaining training in sensory assessment and intervention. Become knowledgeable, become skilled in this area so that you are making solid clinical decisions yourself in the way that you are addressing these needs for your clients, and then move into training others as appropriate. And the recommendation here is not intended to put the burden on you to be training people in sensory theory and sensory assessment, but when we are delivering those sensory interventions to a client who has a substantiated, demonstrated need for them, oftentimes the people around that person also need to understand how to implement. And so the training that happens should be done always in ways of connecting the intervention techniques and strategies that you're using, linking them back to the assessment data and using that data as the rationale for why a particular intervention has been chosen, why it's being implemented in the way in which it's being implemented, and what the person should be looking for as a sign of response to the intervention, or perhaps even signs that the intervention should be modified, changed, or discontinued. Secondly, I want to really encourage practitioners to develop skills in being able to explain to other professionals that sensory concerns that they may have around an individual child are really no different from concerns in other areas. And therefore, interventions really need to be based on data. I think a lot about the way speech pathologists practice or behavior analysts practice, and they're constantly collecting data on their clients and then making their intervention decisions based directly off of that data. And there is no reason that any other professional should expect occupational therapists to practice without first collecting data. And so again, this recommendation is in alignment with best practice, and it really is something that others should be expecting us to do rather than expecting us to provide intervention without first having the assessment data. And then finally, another encouragement to you as individual practitioners to establish a standard for yourself to require access and time to administer, score, and interpret appropriate assessment tools before you move into thinking about and making recommendations regarding interventions. I know that there are facilities around the country where there's kind of a pressure and a rush to get moving on to implementing intervention, and there can be those pressures again to cut the evaluation short. But what that really does ultimately is it compromises the quality of care that you're delivering, and it compromises your professionalism as well. And so I think that it's really important for us as OTs to establish high standards for ourselves. And as we begin to do that, others will see that, and they will begin then to expect that we maintain those higher standards. So again, requiring access to appropriate tools, requiring sufficient time to evaluate this particular area of need for your clients, and then taking the time to score and really interpret the data, not just looking at the distribution of scores or how far away from the mean score is, but really looking at what is the underlying function that was measured and how is that representation of the client's function informing what should be done regarding any interventions that might possibly be delivered. Okay, so that concludes my time on recommendation number 2, and I'm going to turn it over now to Dawn Nilsen for recommendation number 4.
Thank you, Renee. So I'm very happy that AOTA chose recommendation number 4 as part of their 5 recommendations, because it allows us to have a conversation about abandoning a practice that can potentially cause our patients great harm. And I do want to point out that this recommendation is consistent with best practice and, in fact, is consistent with the American Heart Association and American Stroke Association's guidelines for adult stroke rehabilitation and recovery with respect to the assessment, prevention, and treatment of hemiplegic shoulder pain. And this is because this type of exercise is really just considered too aggressive for a compromised shoulder, and it really places our patients at risk for developing secondary injuries, soft tissue injuries such as tendinitis and bursitis and rotator cuff tears. So it's really something that we just want to stay away from. Now, just as a reminder and to show just how compromised the shoulder can be after stroke and why we want to stay away from these types of aggressive exercises, I just want to remind you about the biomechanics of the shoulder joint. So in order to raise our arm over our head, there's a real intricate relationship between scapulothoracic mobility and mobility at the glenohumeral joint proper. And so we need to have this ratio of movement between the scapula and the glenohumeral joint. Scapula upward rotation is really instrumental, and external rotation of the humerus, very important in order for the greater tubercle of the humerus to clear the coracoacromial arch. So just as a reminder here, we're looking at the subacromial space, and we'll talk about that in a little bit more detail in a moment. But after stroke, we know that it's quite common for patients to have patterns of muscle weakness. and changes in muscle tone that compromise the biomechanical alignment of the joint. So shoulder subluxations, for example, are very common after stroke. Decreased mobility around the scapula and an inability to upwardly rotate the scapula is really prominent after stroke. And so if we go back to this subacromial space, what we can see is that there are some important structures, right? The tendon of supraspinatus, one of our rotator cuff muscles, the long head of the biceps tendon, of course, the subacromial bursar, which protects those tendons from the overlying acromion process. And so if we don't have normal upward rotation of the scapula with normal rotation of the humerus, we can actually impinge those structures underneath that coracoacromial arch, creating great damage. And so again, we have to respect the normal biomechanics of the shoulder joint and really be paying attention to that when we're mobilizing our patients' arms after stroke. Now, why do practitioners engage their patients in overhead pulley exercises? Why is it being done? Well, one of the reasons why I think practitioners do this is because they want to maintain shoulder joint mobility, right? And that's a really good thing, and we really do want to do that. The hope is that our patients are going to gain motor recovery, and then they're going to be able to use their arms. So we want to maintain that joint mobility to allow that process to happen. So maintaining shoulder joint mobility is a really good thing, but we just have to rethink how we go about doing that. And so what I want to do now is to talk about some alternatives in order to maintain shoulder joint mobility in a safe way. So one of the things that we know after stroke, again, particularly related to changes in muscle activity around the shoulder, is that the limb, very heavy, being pulled down by gravity. Again, we've got the potential for shoulder joint subluxation. So one of the ways that you can deal with this is by taking the weight of the limb up, by placing the limb on a table, for example, reducing friction by placing the involved extremity on a towel, and giving the patient some targets that simulate reaching forward for a target and encouraging maintenance of that shoulder joint mobility. In this kind of a situation, the therapist's hands are often left free so that mobilization of the scapula can occur as well as incorporating the trunk into the movement. So this is a safe alternative for maintaining joint mobility and engages the patient in a self-range of motion process. Another possibility for maintaining shoulder joint mobility and teaching your patient self-range of motion techniques is what we call rock the baby, which you see pictured here. And so in this case, the affected arm is cradled by the less affected arm, and the patient is encouraged to lift the arm to shoulder height and then to move the arm in side-to-side motions, also incorporating trunk rotation. And so this allows for, again, safe mobilization of the shoulder by taking the weight of the limb up and by really preventing the possibility of impinging those structures under the subacromial space there. Another recommendation that you can consider incorporating to maintain shoulder joint mobility is to actually encourage our patients to use the involved extremity as much as possible during activities of daily living. So, for example, using the involved extremity as a stabilizer or support during common activities. In this case, weight bearing is being taken through the affected limb. So the distal segment is fixed, and the patient is encouraged to move the proximal segment over the fixed distal part of the extremity. And so in this way, weight is being bared through the affected extremity. You can do this in full arm extension, as you see pictured here, so bearing weight through the arm while using the other arm to perform various activities like wiping and drying a table, for example, or even putting groceries away in a cabinet while in the standing position, for example. You can also incorporate this type of weight bearing through the affected forearm while engaging in transfer types of activities, for example, bed mobility while pushing up to a sitting position. So again, the idea of really trying to engage the patient in using the extremity in ways that are safe. So again, I think recommendation number 4 is really critical. It allows us to talk about abandoning a practice that could potentially cause our patients harm, something that we really want to avoid. And there are multiple ways that we can encourage the maintenance of shoulder joint mobility without exposing our patients to harm. And so I'm going to now open up the platform for questions. And I believe we're going to start by turning it over to Phyllis, and she will take the first question.
I believe somebody made a comment and a question that came about before that was just about the use of group and concurrent treatment. And I think this has been a hot topic and a big change for many clinicians that they've had to adapt to. And again, I just want to encourage people that this is a fabulous opportunity to really use occupation-based activities and things that are meaningful. Of course, we have the benefits of also social interactions and socialization for our clients. So I appreciate that someone mentioned that before. If anybody else has questions about it.
This is Renee, and I'm going to address one of the sensory-based questions that's been posted. There's actually 2 questions that are asking about application of this recommendation beyond looking just at children. And I do want to address that. I think that while the recommendation focuses on children, it really does apply across the lifespan as well as across the full range of occupational therapy. I mean, evaluating and having evaluation data prior to implementing intervention is certainly not unique to sensory needs or to children. But the idea of looking at sensory needs across the lifespan, I think, is an area where occupational therapy can really contribute more to what we have, to what we offer to adult clients. And there's not well-established practices in terms of the way to structure that type of service delivery or even to obtain reimbursement for it. But I do know that it's very real to have sensory-based needs, occurring across the lifespan. So those of you that are working with adults may want to be incorporating consideration of sensory needs into your sessions. One of the questions asked specifically about measurement tools that could be used, and there are a few that look at sensory issues in adults. This newer sensory profile 2, goes up through adult ages. The SP3D, which is currently in development, should be available soon, is another tool that is going to have some norms for adults. The sensory processing measure 2 is also developing a version that can be used with adults. And then there's an older tool that was developed by Judith Reisman and Bonnie Hanshu, the Sensory Integration Inventory Revised, which was designed for adults with developmental disabilities, and has some wonderful items on it that really begin to look at sensory-based behaviors in adults. So yes, those of you working with adults, please do be looking at this area for your clients and using the tools to gather data that you can then make your intervention decisions based off of.
Okay, I'm going to take a question here related to recommendation number 4. And the question is, are you aware of any lawsuits against OTs for causing shoulder damage by using inappropriate techniques? And so the quick answer to that is no, I'm not aware of any lawsuits that have been brought against OTs, either in the past or current. However, I do think we open ourselves up to liability if we engage our patients in techniques that we know can be potentially harmful. So I would say just abandon this use of overhead pulleys. I think there is significant evidence to suggest that it can cause harm. Again, this recommendation is highly consistent with what's come out from the American Heart Association and American Stroke Association. And so, again, I think we just need to figure out safer ways to mobilize the shoulder. And aggressive exercises such as this are not the way to go.
Okay. I'm going back. This is just a question. Also, a clinician expressed some concern about having to bring in or purchase occupation-based supplies, and that employers, the challenge of sort of how do you get supplies. We know that budgets are limited, time can be limited. However, I think it really takes the creative therapist to utilize what's available to them. And it can be, the patient's own grooming items, or it can be even asking the administrative staff or the activities. I know I personally practice in a subacute facility, and the activities people are always handing out menu, whether it's a menu or a flyer or posting things, or do things need to be filed? Can they copy things can they file things? Be creative about what you can utilize within the facility, whether they can sort, plastic wrapped cutlery. So I think it just takes a little bit of thinking and generating ideas. It might be a nice lunchtime activity for your staff to sit around and just generate some ideas. Look around what's there. Think about different types of activities. You can even pick a problem or a deficit and just generate a list of activities and ideas given the things that are in the environment around. So that's my suggestion that may help. It's definitely a big challenge in terms of budgets. So good luck to that.
I'm going to address a comment that was posted, and it says, I worked in EI, and often another discipline would recommend SI before I was able to evaluate and know the child. This would put me in an uncomfortable situation by making this comment to a parent. More often than not, what was suspected as an SI problem was really a behavior problem. And I appreciate this comment being posted because I think this illustrates a very, very common scenario where an occupational therapy is working in a multidisciplinary type of facility, so many other professionals perhaps being present, and another discipline interpreting something that they see in the child as being representative of a sensory-based need, and talking about that perhaps with other professionals or even with the child's family, and creating then an expectation that the OT would be able to address the sensory need, and that would therefore address the concern that was being present or being recognized. And this is a place where OTs, again, need to be really skilled at understanding what is a sensory-based behavior and what is not. And we really need to become better at being detectives and figuring out how are we going to assess the the underlying sensory components of these behaviors that are of concern. I agree, it is very, very common that some things that look sensory on the surface actually have a behavioral basis to them. And we need to develop our skill sets in both areas in order to be able to do that kind of discrimination. So it is an area of practice where people need to be continually learning and developing their skills, and also developing their confidence in being able to talk about these things in a well-informed way. So I would encourage folks who are working with children to not only pursue training in the sensory methodologies, but also to pursue a deeper understanding around behaviors and behavior methods for intervention, and how we can use things like functional behavioral analysis approaches to begin to analyze the behaviors that we see our kids demonstrating so that we can determine, are they sensory in nature or are they behavioral in nature? If we were to provide intervention that's targeting the wrong underlying function, we're not going to be making a difference with our interventions. And so it's really important that we are layering on this behavioral lens in addition to the sensory lens as we're working with kids who are demonstrating these challenging behaviors. And again, this is something that doesn't end in childhood, so we could extend this same conversation to individuals across the lifespan.
Okay, so I'm going to address another question that was posed regarding recommendation number 4, not to use overhead pulleys. So the question reads, what about pulley in a horizontal plane and not above the shoulder? This would be in addition to the recommendation suggested. Thanks. So I'm not familiar with what this would look like. I can kind of envision this, and my recommendation is going to be to stay away from this type of exercise as well. Again, whenever you're engaging in a pulley and the person's using, the non-effective arm there to just sort of drag the arm, you still got the weight of the arm to consider. And so I think that that's another potential way that we could be causing harm to the shoulder. So again, I would really go back to trying to figure out gentler ways to incorporate shoulder mobility and really think about ways to incorporate use of the affected limb during common activities of daily living in ways where you can actually mobilize the shoulder by fixing the distal part of the extremity and mobilizing the proximal segment over that fixed distal segment. There are also several courses that people can take related to treatment of the hemiparetic shoulder. There's books that you can read about this as well for additional ideas. And there are resources on AOTA's website. So I just think we should put the pulleys down and step away.
That was great. Okay, I'm back. This is Phyllis. Looks like there's a couple of questions that sort of have the same type of theme about strategies for implementing and resources that might be available for some of these kits or ideas, because that is the time-consuming challenge I think that clinicians face. And that's one of the reasons I think we go to things that are just available and easier to utilize. So some of the strategies, I think somebody said, can you share some personal experiences with implementing these recommendations? And some of the things that I've done actually, it's a wonderful student project, actually, to have students create theme boxes. And I believe, actually, when we presented at AOTA, there was somebody who was also developing from a business end of creating and making these boxes available to practitioners. So there are some suggestions, and there are handouts that are available on AOTA's website. And somebody also posed, the second part of this question says, have your coworkers been supportive of implementing these recommendations? And if they weren't, how do you deal with this? And it is a challenge sometimes, and I know it's hard to move into a different realm, but very often I find myself that people are saying, oh, I never thought about doing something like that, or really demonstrating that it is possible, it is feasible. I've gone into, our kitchen and taken out sort of a cutlery sorter that we had. You don't even need that. You could actually just have a client sort utensils or products into different, like spoons, to make available during snacks or lunch times, or things that are available even to staff. So different ways. Again, I think it takes one person sometimes, or a group. There are going to be people that are going to stick to their comfort zone, but I think the more that people get comfortable with utilizing it, the more that they see it, the more likely that they're going to use their training and their skill sets in activity analysis to find ways to implement more purposeful activities.
This is Renee again, and I'm going to address here a comment that was posted that relates back to the last conversation that we had around the sensory and the behavior potential foundations for observed behaviors. And the comment is, isn't it documented knowledge that sensory drives behavior? And I think it's really, really important that we talk about this because while sensory issues that exist within an individual's, I'm going to say their physiology and the way they process sensory information, yes, that can drive behavior, but that is not always the case. There is an extensive body of knowledge, of evidence that shows us that behavior can have multiple different purposes and functions. And that means that what is driving the behavior can come from multiple different sources. So what is recognized as those primary sources that can drive behavior is the function of escape. So the child wanting to get away from a person, a demand, a situation that they're finding themselves in. Escape can drive a lot of behaviors. Acquisition of tangibles or access to attention can also drive a lot of behaviors. And I actually believe that access to attention is one of the biggest ones that we often misinterpret as being a sensory-based behavior, where kids can do all kinds of behaviors that on the surface have a sensory characteristic to them. But what happens as a result of that behavior is that the child receives a lot of attention. That attention then becomes reinforcing, and the child uses that behavior over and over again because they know they're going to get the attention for it. And attention isn't always, from the adult perspective, a positive type of attention, but to the child, it is still a reinforcer for that behavior. So when we're looking at what is the underlying driver to behavior, we need to be thinking much broader than just sensory and looking at these other functions and these other sources of reinforcement that influence behavior and really being discriminatory around how we're identifying what is the actual driver to that behavior.
Okay, so I think we have handled the majority of the questions that have come through, and so I'm just going to close our webinar out. We really thank you for joining us, and we hope that you have learned about AOTA's 5 recommendations and that you'll visit AOTA's site. And we hope that you have gained some strategies here on how to implement 3 of these recommendations. And we just want to briefly tell you about the Choosing Wisely Champion. So getting involved and sharing your success stories is really important for all of us to integrate Choosing Wisely recommendations. So again, visit the Evidence-Based Practice and Research on the AOTA.org website. And for information about the Champion Recognition Program, you'll find that there as well. And this is a great opportunity to share your stories and to find more about the project. Thank you very much for your attendance. Have a good day.